Good evening, everyone. My name is Yasmin Hernandez Barco. I am from Mass General Hospital, and I want to thank the organizers of this event for inviting me to speak tonight on the etiologies of pancreatitis with a focus on genetics. Here are my disclosures. None are particularly relevant to this talk, and I do have one additional disclosure whenever talking about genetics that I'm a medical pancreatologist and not a geneticist, but I do order genetic testing. And so I hope to share some of my practice with you tonight as well. So the learning objectives for today's talks are to provide an overview of the diagnosis and etiologies of pancreatitis, learn when to order genetic testing in pancreatitis, and learn how to order genetic testing for pancreatitis and the potential implications on monitoring and treatment. This is a brief outline. I'll go through the natural history, etiologies and risk factors, what are the mechanisms of disease, and then who, when, how to test. I'll end with a case and then discuss a little bit how to manage patients once you have those results. Acute pancreatitis, as we know, is a leading cause of GI-related hospitalizations every year, with nearly 300,000 patients hospitalized each year. And healthcare costs are upwards of $2.5 billion. And the incidence of acute pancreatitis seems to be increasing with age. And while there's been great strides in improving the mortality in acute pancreatitis, and it's quite low at about 1%, there's significant morbidity associated with this disease. I always think about pancreatitis on this spectrum, and I talk to my patients about it in this way as well. It starts with acute pancreatitis. It can be mild or more severe forms, including necrotizing pancreatitis. But about a third of patients will go on to develop recurrent acute pancreatitis, and a subset of these patients will go on to develop chronic pancreatitis and the complications that are listed there on the far right-hand side. And so when you think about what's called the SAPE hypothesis, or the sentinel acute pancreatitis episode hypothesis, this proposes that there is some kind of initial event that causes inflammation to the pancreas, and it leads to a cascade of events that can predispose the patient to progressing through this pathway and developing more severe or even irreversible disease. And what this highlights is that if we can intervene early in the disease, we may be able to prevent recurrent episodes or even progression to chronic pancreatitis and its complications. I have here listed some of the most common risk factors, and I say this in essentially all of my talks and in every patient encounter that I have. We really have to try to figure out why. Why do you have pancreatitis? And I think it's just absolutely critical, because if we can intervene and prevent recurrence, we've done an important thing. Alcohol and gallstones have been most commonly implicated in acute pancreatitis. So I put here, as you can see in yellow, that alcohol is likely a risk. In my talk, it is genetic. So there's probably, more of a genetic predisposition here. It's not just alcohol. I put in quotes. Hypertriglyceridemia, post-ERCP pancreatitis are also common etiologies. Medications can cause pancreatitis, though I caution to blame one medication and then the patient can never get it forever. So really careful discussion about when it was given is important. Toxins such as tobacco can increase the risk of progression to chronic pancreatitis. Of course, young patients with family history, recurrent acute, you want to think about genetic mutations and anatomical or structural causes, and especially in older patients with their first episode. There's no other clear cause. Always think about pancreatic cancer, and then infections or autoimmune causes also are risk factors. In this slide, I want to introduce the Tiger-O criteria, and it was really developed to help quantify and identify the different risk factors and etiologies. So I mentioned risk factors, not just the cause, but really what is the combination of factors that can make your pancreas more sensitive to pancreatitis and that can lead to recurrent acute pancreatitis. And so here, this slide really quantifies things. And again, you can see from my prior list that biliary causes are quite common. Here in the next slide, I want to focus on using the Tiger-O as a framework. And I use this even in my patient, even though it was developed mostly for recurrent acute pancreatitis and chronic pancreatitis, I use this in every single patient when I think about them, even if they've had one episode of pancreatitis. It really helps me to be very organized and thoughtful about every potential etiology and have these detailed discussions with patients. And so in order to evaluate toxic metabolic factors, I do check triglycerides and calcium levels in almost every patient. For idiopathic, I'll make sure that I get an MRI or an endoscopic ultrasound, which Dr. Park will talk about in the next part of our CAPER session today. Genetics, I will talk about in a few moments. For autoimmune pancreatitis, one point is I don't check an IgG4 in everybody. I only do so if I think they may have autoimmune pancreatitis. And then in the far right column, sort of the obstructive causes, really, does a patient need a cholecystectomy? Do they need follow-up to make sure that they don't have a cancer? And so the reason why this framework is so helpful is because we have all these different causes up here that lead to pretty much the same outcome potentially, but the treatment and approach may be different depending on the cause or risk factors for your pancreatitis. And I'll use the example of autoimmune pancreatitis because in patients with suspected type 1 autoimmune pancreatitis, for example, the pathophysiology is actually quite different. And so you'll look for extra organ involvement, and these patients do benefit from either steroids, immunomodulators, or even biologic therapy. And it can have a significant impact in altering the course of their disease and potentially prevent complications. So at this point, I do want to focus the rest of my talk on genetics. And so the first question I want to focus on is, who do we test? And there have been several papers and guidelines that suggest to us that we should test young individuals, less than 35 years of age, but probably every single patient under the age of 18. There are several studies that have shown that in children that have recurrent acute pancreatitis, the presence of a genetic mutation as the cause of their pancreatitis is nearly 60%. So it's definitely something that we want to do in young patients. We want to consider genetic testing in those patients that have quote unquote idiopathic recurrent acute pancreatitis or idiopathic chronic pancreatitis where no other cause has been identified. We'll want to check in patients with family history of recurrent acute pancreatitis or idiopathic chronic pancreatitis, and certainly in patients that have family members with a known mutation that causes hereditary pancreatitis. And lastly here, I want to potentially argue that we want to test everybody with early signs of the disease or this syndrome. So perhaps we're going to have a world where we want to test almost anybody that's had pancreatitis just to see if there are potentially modifiable risks, but I'll discuss that a little bit later. So now I want to focus on the mechanisms of disease. So in thinking about how genetic mutations can impact the pancreas and pancreatic function, I do want to review very briefly the normal function of the pancreas. So this is the major subunit in the pancreas, which is composed of the pancreatic acini, which is here, this top part here. So pancreatic acinar cells, they're protein synthesizers, and then you have the pancreatic ductal cells, which collect these enzymes, secrete bicarbonate, and push the fluid with those enzymes out into the into the intestine for digestion. Zymogens are these non-activated enzymes, which are secreted by the acini, of which trypsinogen plays a major role because it's what actually activates all of these digestive enzymes. Trypsinogen is converted into trypsin, and trypsin, as I mentioned, is what activates all of these enzymes and why it plays such a critical role in pancreatic function and also dysfunction. So as you can see here, there are three major pathways that are involved, genetic pathways that are involved in genetic pancreatitis. The first is the trypsin-dependent pathway, of which PRSS1 is the most well-known, and this acts by either converting trypsinogen degradation, preventing trypsinogen degradation by CTRC, or increasing the activation of trypsinogen to trypsin. This is the gene that's most commonly mutated in about 80% of patients with hereditary pancreatitis. And the other mutations that are listed here impact the trypsin-dependent pathway by interfering with the breakdown of trypsinogen. And so you have a pancreas that's just filled with all of these digestive enzymes, and essentially the pancreas is autodigesting itself. The second pathway is what's known as the misfolding pathway. And what this really means is that you have misfolding of enzymes in the acinar cells. The majority of proteins and enzymes in the acinar cells are folded in the endoplasmic reticulum. And when they're misfolded, they cause quite a bit of ER stress that can eventually lead to cell damage and then pancreatitis. And then lastly, we have the ductal pathway. And the most common mutation that we think about when we think about the ductal pathway is CFTR. And CFTR stands for cystic fibrosis transmembrane receptor, which is the mutation that is involved with cystic fibrosis or cystic fibrosis related pancreatitis. There are many classes of gene mutations that can occur in the CFTR gene, but really what's happening here is that you're not able to secrete enzymes and fluids effectively, leading to obstruction and subsequent pancreatitis. And then there are also extrapancreatic risk factors such as hypertriglyceridemia risk, gallstone formation risk, even celiac disease, and some mutations that have been found in the immune response to acute pancreatitis. And so it really is, one of the things I want to emphasize is that pancreatitis is really a complex disorder of which genetics plays one major role. So the next question that I want to answer is, what do we test? So traditionally, and the majority of the gene panels, and when you work with genetic counselor, they will include 4 major genes: PRSS1, which is the cation, encodes for cationic trypsinogen, which is the gene that's involved in 80% of hereditary pancreatitis; SPINK1, which is a trypsin inhibitor involved in familial chronic pancreatitis; CFTR, which is a cystic fibrosis or cystic fibrosis related disorder gene, or CTRC. These genes are inherited by very classic Mendelian genetics. And so genetic counselors will counsel patients, they'll do this testing, but oftentimes in patients with pancreatitis, we don't always find a gene because only 5% of patients with pancreatitis will have one of these, what's considered monogenic or disease-causing mutations as the cause of their pancreatitis. A separate concept is something of disease-modifying or risk variant mutations. And so the way I explain it to patients is that you don't have a monogenic cause. You don't have one of these mutations in PRSS1 or SPINK1 or CFTR or CTRC that by itself is just going to cause your pancreatitis, but you have risk variants that make your pancreas more sensitive to everything else: alcohol, tobacco, something in food that we haven't yet discovered. So that's sort of how I talk to patients about genetic testing. I do want to talk about genetic counseling because the American College of Medical Genetics recommends that informed consent is obtained for all patients that are having testing for strong or pathogenic variables, such as those 4 genes that I showed on the left-hand column. And genetic counselors are exceptional. I work with them very, very frequently, and they serve a very important role in helping patients determine the best testing for them. I will always send a patient to a genetic counselor if there's a known mutation in the family or a very, very strong family history of pancreatitis, because the likelihood that they're going to have one of these monogenic pathogenic mutations is quite high. Now, depending on what state you live in, we're in Massachusetts, so Massachusetts does require that we have written informed consent and that at least the physician provides genetic counseling to patients, but genetic counseling is not always required for evaluation of risk variants, such as the ones that are offered by aerial precision medicine, which gives you more of a risk score. And because these variants are quite common in the general population, it really, these are genes that you want to test when someone has active disease or they've had pancreatitis, because then in those situations, the likelihood that those mutations are the cause or at least contributing to the problem is high. There are barriers to testing. Even though we know, and we've discussed already a little bit, that genetic variants contribute to pancreatitis, there are quite a lot of barriers. Cost is one of them. Oftentimes I've, ordered genetic testing, and some of my patients will have $25,000 bills, and we're retroactively getting authorization. And so really cost is quite prohibitive. And then also insurance coverage is not there across the board. And oftentimes you'll need prior authorization, and Medicaid patients aren't covered. So there is a bit of difficulty in the cost and insurance coverage. Also, the availability of testing. It may not be available in all centers. In certain outpatient practices, referral times might be quite long. And then really knowing what genes to test for, I think, is a big question that can be a bit of a barrier. The lack of administrative support to help submit the prior authorizations and provide documentations and paper is another barrier. And then genetic counselors really have long wait times because they do a lot of broad medical genetic counseling. And so just being aware of these barriers, I think, and creating an infrastructure that works for your practice is important, in my opinion. I want to discuss a case of a patient of mine. So she is a 31-year-old female, Caucasian, has a history of heavy alcohol use disorder, now in remission, and she presented for a second opinion for the etiology of her pancreatitis. She had one episode of pancreatitis where she presented with a few days of abdominal discomfort and some reflux. It wasn't associated with eating, bowel movement changes. And then she woke up one morning with 5 out of 10 pain, epigastric area to the right upper quadrant, and it increased in severity as the day went on, and she had nausea, vomiting, and then loose stools. This was in mid-2020, so she went to urgent care. Her labs were notable for a lipase of 141, and her ALT and AST were elevated at 369 and 276. Her CT scan showed mild interstitial pancreatitis. She hydrated at home because it was during the pandemic, as I mentioned, and then she went to see her outpatient GI about a week and a half later. Her lipase had normalized, but her ALT and AST were persistently elevated. She did mention that prior to this episode, she had an almost identical episode in March, but didn't seek medical care. So what is next in the medical evaluation? In her case, I should mention she had a thorough history taken. She hadn't been drinking any alcohol. Her calcium was normal, triglycerides were normal. And so all of that initial workup was normal. So I ordered an MRCP. The MRCP was normal, and the reason for that was to make sure there were no sludge, stones, or any anatomical issues that could have contributed. And then I referred her for an endoscopic ultrasound, which showed pancreatic parenchymal abnormalities that can be seen in resolving pancreatitis. So at this point, I have a woman that had one, potentially 2 episodes of pancreatitis, so recurrent acute pancreatitis, with no obvious trigger other than she's 31 years old, she's quite young, and I don't have another cause. So at this point, she also mentioned she had recurrent sinusitis as a child, some digestive issues. She was told by many doctors it was anxiety. And so at this point, I recommended that she do genetic testing. I ordered genetic testing, which included CFTR, PRSS1, SFNC1, CTRC, and risk variants. And what I found was that she had, this first one here is a pathogenic mutation in CFTR. And then she had all of these risk variants listed below. So many other mutations in CFTR, and then mutation in SLC26A, which A9, which can sort of make the CFTR mutation a little bit more pronounced. And so at this point, I sent her for sweat chloride testing. Sweat chloride testing is a test that is done in the setting of a CFTR mutation. It measures how much chloride is being secreted on the skin, and it gives you a sense of how functional the CFTR receptor is. And in her case, it was only intermediately functional. And so I diagnosed her with cystic fibrosis and referred her to the pulmonary team. She was started on Trikafta, which is one of the medications for cystic fibrosis that's been approved, and she's doing pretty well. So I use that as an example of a patient. I have many, many patients that present in a very similar way. She happened to have cystic fibrosis, but I also have many patients that have risk variants without one of the pathogenic mutations. So I just want to take you through what I do when I get these results. So You have multiple options of what the results will show. They will show either a positive pathogenic mutation. If I have a positive pathogenic mutation in PRSS1, which is associated with hereditary pancreatitis, I will refer to a genetic counselor. These patients are at higher risk of developing pancreatic cancer. The thought was that it was 40 times higher than the general population. It's probably a lot lower, especially if tobacco use is completely stopped. But these patients, you want to consider enrolling them in a high-risk individual surveillance program for pancreas cancer at least 10 years after their first episode of pancreatitis and 10 years younger than the onset of pancreatitis in their family. And knowledge of having this mutation may change your surgical considerations for patients that need surgery, because you may need to consider a total pancreatectomy in these patients. For patients that have a CFTR mutation, my approach to managing them is also to refer to a genetic counselor. I will often have the cystic fibrosis team do full sequencing of the CFTR gene, because in the last few years, there are multiple CFTR modulators that can actually be used to manage cystic fibrosis. And so I want to determine if they qualify for one of those medications. And then I always refer them to the Cystic Fibrosis Center for pulmonary function and to determine if they can be treated with CFTR modulators. And then with all patients, alcohol cessation, tobacco cessation, high antioxidant diet, and avoidance of red and processed meats. The other potential outcomes is that you can have a positive risk variant. In these patients, we don't have drugs that can actually help reduce their risk of pancreatitis, but we want to provide counseling, alcohol cessation, tobacco cessation, antioxidant diet, avoiding certain high processed foods that can make pancreatitis potentially worse, and also modify any other genes such as gallstones or lipids. You can also end up with a variant of unknown significance or negative testing. In these patients where I do not find a gene, or I find a gene where I don't exactly know what to do, I provide the same counseling as though I had found a genetic mutation, but I continue to follow patients because genetic testing always evolves over time. And these are patients that if something new comes out, I certainly want to offer them the opportunity for retesting. So I'll end here. So the key takeaways are pancreatitis is a complex disorder with multiple possible etiologies. All patients should be carefully evaluated to understand which etiologies and risk factors might be contributing to their presentation so that steps to prevent disease progression can be taken. Genetic testing should be considered probably in most patients, but especially those that are young, recurrent acute pancreatitis, chronic pancreatitis, or with a known family history. Monogenic causes of pancreatitis only account for 5% of genetic pancreatitis cases, but do require a genetic counselor. But that's always not the entire story, because there are also risk variants that can contribute to a patient's disease, and these risk variants should be explored in order to modify an individual patient's risk to prevent disease progression. I really, again, want to thank you all for your attention and for the organizers of this course. I'm happy to take questions either now or via email later on. Thank you.
Thank you so much, Dr. Barco, for this wonderful presentation. What I would ask the audience is to put in some questions in the chat box so we can ask Dr. Barco at the end of the presentation. We have one more presentation by Dr. Park. I'd like to take this opportunity to welcome her. She's a gastroenterologist and pancreatologist, as well as an advanced endoscopist at Ohio State University. She's going to talk to us about the role of endoscopic ultrasound in idiopathic pancreatitis. Dr. Park, the floor is yours.
Thank you. Let me just pull up the presentation. All right, can we all see? All right. So hi, I'm Erica. I actually just completed my interventional endoscopy fellowship at Ohio State this past year and stayed on as faculty. Thank you to the organizers for inviting me to speak today about diagnostic EUS and idiopathic pancreatitis. In up to 10% of patients with a single episode of acute pancreatitis, and in up to 30% of patients with recurrent acute pancreatitis, the etiology of the pancreatitis is not identified after initial evaluation. Most etiologies of acute pancreatitis can lead to recurrent attacks if the underlying etiology is not treated, and it is important as 50% of untreated patients with recurrent acute pancreatitis, up to 50%, can lead to chronic pancreatitis. So as previously mentioned, initial evaluation of acute pancreatitis includes history, including medications, family history, exam, physical exam, lab work, including LFTs, calcium triglycerides, transabdominal ultrasound as well to evaluate for gallstones. If an ultrasound is equivocal, providers may also order standard imaging such as a CT with contrast or MRCP. Potential obstacles to identify etiology of acute pancreatitis include things such as microlithiasis, which might not be well detected on standard imaging. Ongoing pancreatic inflammation and necrosis can prevent adequate visualization of the pancreas on standard imaging, and then biological abnormalities during the initial days of acute pancreatitis may make it difficult to identify etiology. Various diagnostic studies are available at this time to investigate the etiology of acute pancreatitis, and of this, EUS is emerging as a diagnostic tool of choice. So the diagnostic yield of EUS really varies from study to study, anywhere between 29 to 80%, so quite a range. In a 2018 systematic review in GIE, 34 studies were evaluated to determine the diagnostic yield for both EUS and MRCP in idiopathic acute pancreatitis. And among these studies, EUS did have a higher diagnostic accuracy compared to MRCP at 64 versus 30% in determining the etiology of the IAP. Notably, in the subgroup analysis of chronic pancreatitis and biliary disease, EUS was superior to MRCP, and this was statistically significant. So prior to EUS, ERCP was a primary diagnostic and therapeutic endoscopy tool for determining the etiology of acute pancreatitis with a yield of about 80% in some studies. In comparison, EUS has a similarly high diagnostic yield, but it does have much less complication rates compared to ERCP, which is closer to 10 to 15%. An added advantage of EUS is that it is more effective in diagnosing biliary and pancreatic tumors, which can cause acute pancreatitis if the tumor is communicating or in close proximity to the pancreatic duct. We then have to ask about MRCP as well. So MRCP is non-invasive imaging that can provide detailed images of the hepatobiliary and pancreatic duct systems. This is useful when diagnosing conditions such as pancreas divisum, choledococele, anomalous pancreaticobiliary junction, or annular pancreas. And advantages of MRCP include that no IV contrast is administered or ionizing radiation, and it is less operator dependent compared to EUS or ERCP. However, some studies indicate that MRCP is less sensitive for EUS in certain conditions, such as microlithiasis, small ampullary tumors, and ductal strictures. There were 2 studies that I could find that directly compare EUS and MRCP in IAP. One was done by Ortega. This was a prospective study of 49 patients with IAP. And in this study, EUS was found to have a higher diagnostic yield compared to MRCP, and this was statistically significant. In a separate study of 40 patients with MRCP negative idiopathic acute pancreatitis, meaning MRCP did not reveal anything, EUS was able to find an etiology in around 55% of these cases, with the most common etiology being occult biliary tract disease, such as microlithiasis. This suggests that EUS is particularly good at excluding biliary causes compared to standard MRCP. I do want to note that the use of secretin stimulation during MRCP, known as MRCPS, has been shown to provide a better diagnostic yield compared to standard MRCP, but this method is not always readily available in centers. So talking a little bit about EUS in biliary tract disease, it is important to acknowledge that abdominal ultrasound has a very good accuracy in detecting gallstones, high sensitivities between 92 to 96%. However, when stones are less than 3 millimeters in size or in the gallbladder infundibulum, the sensitivity of ultrasound can decrease all the way down to 65%. And in a prospective study, this is quite an old study at this point, of 100 patients with acute pancreatitis, EUS was more sensitive than abdominal ultrasound in detecting gallstones, specifically in the common bile duct. In the study, they also reported that ERCP and EUS had equivalent sensitivities for CBD stones, And so to consider, either combined same session EUS ERCP if your suspicion for stone is high so that you can treat it, or if you have a lower suspicion, perhaps just pursuing EUS given the known higher complication rates for ERCP. Additionally, in a systematic review of 13 studies evaluating the role of EUS and IAP, the most frequent etiology in that systematic review was, in fact, biliary tract disease at around 41% of cases. In particular, patients who have an intact gallbladder, the most common cause of IAP can be biliary microlithiasis or sludge, which can be detected in up to 80% of patients. And EUS, I apologize. In the past, microscopic bile examination was considered the gold standard for microlithiasis diagnosis, but this modality can have high false negative rates. It's also time consuming and can very often be non-diagnostic. So EUS has become more of a modality of choice when evaluating for microlithiasis. It's a little more affordable. It's highly accurate in diagnosing biliary disease. I do want to note that the prevalence of microlithiasis does decrease from around 50% down to 10 to 15% in patients who undergo cholecystectomy. This is important to note and something definitely worth asking your patients if they have their gallbladder in or not, as it may affect which modality you choose to pursue to evaluate for other causes, or maybe not even looking at EUS if you have a very low suspicion for microlithiasis. EUS is also beneficial in its ability to diagnose pancreatic tumors. In particular, it has a very high diagnostic accuracy compared to other modalities for tumors that are very small, less than 2.5 centimeters. By catching tumors earlier, you can obviously allow for earlier management and potentially better prognosis for these patients. In a prospective cohort study of 120 patients, EUS was compared to CT for the detection of pancreatic adenocarcinoma, and was found to have a superior sensitivity of 98% compared to CT, which was 86% in this study. And EUS was also found to be superior for tumor staging accuracy, notably equivalent for nodal staging accuracy. In a different retrospective study of nearly 700 patients, these were all patients who had suspected PDAC, who underwent EUS, and 155 of these patients were found to have no mass on EUS. And of these 155 patients, none of them ended up developing any mass of sorts at an average of 25 months of follow-up. The authors of this study therefore concluded that EUS is a very high negative predictive value and is a very highly specific tool when we're working up suspected pancreatic tumors. Pancreatitis is a controversial etiology of idiopathic acute pancreatitis, and various studies have assessed the role of EUS as a potential substitute for ERCP, which is, I think, how a lot of people traditionally are diagnosing pancreatitis. In a study done retrospectively of 146 patients, these patients all had chronic pancreatitis. 20 of them were found to have pancreatitis on EUS. There are two features specifically on EUS. In retrospect, I should have put in a slide of what it looks like on the ultrasound, but there are two features. One is noted as the absence of a stack sign, and the other is when you fail to trace the PD from the body of the pancreas down to the head of the pancreas. Both of these features show a relatively high sensitivity, specificity, and accuracy of diagnosing pancreatitis on EUS. In a retrospective cohort study of 45 patients, all these patients had pancreatitis on ERCP, and then the diagnostic accuracy of EUS compared to CT and MRCP for these patients was calculated. The study reported that EUS had a higher sensitivity than both of these modalities. Again, MRCPS, it may be a different story as it does have a higher diagnostic accuracy compared to standard MRCP, but this modality is not very easily available. So moving on to talk a little bit about EUS for the evaluation of chronic pancreatitis. I know this lecture topic is specifically titled for idiopathic acute pancreatitis, but I think it is important to note that it's often very difficult to differentiate between recurrent acute pancreatitis and early stages of chronic pancreatitis. One thing that EUS is very good at is identifying pancreatic parenchymal changes of chronic pancreatitis, and it can be very reliable. We have Rosemont or conventional criteria that might help us identify patients with chronic pancreatitis early. And interestingly, there was a study done, it's a pretty old study, but in this study by USOF, EUS findings consistent with chronic pancreatitis were actually the most common finding in the patients with IAP, specifically those with recurrent attacks. So they do seem to kind of coincide with one another on the EUS in these cases. This table right here is the Rosemont criteria. Essentially, it's findings that you can see either in the pancreatic parenchyma or duct, and they're divided into major criteria and minor criteria. And depending on a combination of these criteria, you can establish your diagnosis of chronic pancreatitis or rule out a diagnosis of chronic pancreatitis. Lastly, I'm going to quickly touch on timing of performing EUS for idiopathic acute pancreatitis. There is controversy in the literature on the timing of EUS, especially whether it should be performed after an initial attack of acute pancreatitis or wait until there are recurrent attacks. In that study by USOF, they found that the diagnostic yield of EUS was not significantly different after a single attack or recurrent attacks of IAP. So they concluded it's reasonable to perform EUS after the first episode. There was another study in 2016 that I thought was interesting. It was a prospective study of 201 patients. And the authors did find that following a single idiopathic attack of acute pancreatitis, if the patient had a negative EUS exam, they noted that the relapse rate was very infrequent in these patients, which suggests a potential prognostic value with EUS as well. So given the variety of literature, the suggested diagnostic approach regarding if we should do it before recurrence occurs or after a recurrent attack is very variable amongst the guidelines. ACG just came out with updated guidelines this year on management of acute pancreatitis. And they do say that EUS or MRCP is recommended following recurrent attacks of IAP. It's not necessarily recommended after a first episode of acute pancreatitis in patients who are young, but they do recommend EUS for patients over 40 presenting with acute pancreatitis as their risk of a pancreatic tumor is higher. For the International Association of Pancreatology, in their guidelines in 2013, they recommended that patients with IAP should undergo EUS irrespective of whether they have had one or recurrent episodes, and then to consider MRCPS if negative. And then in 2022, the AGA also provided updated clinical practice guidelines for acute pancreatitis. And they suggest that if the initial evaluation, including your standard workup, including abdominal ultrasound, is unrevealing, EUS is their preferred diagnostic test for unexplained acute and recurrent pancreatitis. The other area of discussion regarding timing is the length of time between the acute pancreatitis episode and the EUS evaluation. Different studies have used different timings. Most studies, I would say, wait at least 4 weeks before performing the EUS. I've seen some studies where they do it same admission, as long as the patient's able to eat, they can get their EUS done. But the reason why most providers, most interventional endoscopists wait some time to perform an EUS is because the active inflammation and necrosis really can prevent your visualization of the pancreas during the acute phase. We've done it. It's a pain. Everything's dark. It just looks like inflammation. It's really hard to discern if you've looked at the entire pancreas, if you've missed any sort of pancreatic lesions that might be hiding within the inflammation. Disadvantages, though, of delaying EUS too long include missing early diagnosis of lesions such as ampullary stones, small periampullary tumors or pancreatic tumors, and patients may also be lost to hospital follow-up if they're given an outpatient EUS for follow-up rather than doing it that admission. And further studies are definitely needed to determine an optimal timing for performing EUS. So in conclusion, just some takeaway points. Given that there's a high incidence of biliary tract disease like microlithiasis, as a cause of idiopathic acute pancreatitis. And knowing that EUS does have a high diagnostic accuracy, and specifically for biliary disease, EUS should be considered as an initial diagnostic step for IAP. Mixed data, but overall, there appears to be some support for performing EUS after the first episode of IAP and not necessarily waiting for a recurrent attack. So EUS, I would conclude, as a first strategy towards the etiology evaluation of IAP does appear to be useful based on the literature. Thank you so much again, CAPER, for allowing me to speak at this webinar. Can take any questions now at this time.
Thank you so much, Dr. Park, for this wonderful presentation. Do we have any questions? If the audience has any questions, they can put it up in the chat box. Or they can, none. Okay, so there are no questions, Dr. Park, so I'll ask some questions to you then.
Okay.
So let's imagine we are all working in referral centers. We see patients who have an acute pancreatitis attack, have a CT which shows pancreatitis, and they see us after a few weeks in our clinics. Now, usually what we end up doing is ordering an MRCP because we want to look for anatomical features and stuff, as well as kind of helps us characterize the ductal anatomy as such, and has a follow-up for the initial image that showed pancreatitis. Now, if that is a good quality MRCP, would you still advocate an EUS?
I think if the MRCP quality is good, at least at OSU, that suffices for us.
Yeah.
I think where it gets dicey is especially older patients who have maybe not such a high quality MRCP. We have seen anecdotally, at least at our center, which is also a tertiary referral center,
Sure.
missed pancreatic lesions, and then months later they'll come back with a metastatic lesion to the liver, unfortunately, and progression of their adenocarcinoma if they have one that was missed at the time. But I think if your quality of your MRCP is good, reflecting guidelines like ACG, I think an MRCP can provide just as good data as EUS can. You're at Ohio too. I'm sure the quality of MRCP is not always great for our patients, unfortunately.
I agree. But oftentimes we see, patients undergoing just for a single episode, extensive investigations in spite of good quality MRCP. It can be done in that select subgroup of patients as you spoke about, but we should always kind of select our investigations more judiciously. I agree to that. I'll probably ask Dr. Barco some questions as well. Dr. Barco, you there?
Yes, hi, can you hear me?
Right. So what do you think about people with multiple genetic variants? Like, are they at increased risk compared to people with a single variant or a mutation?
It depends on the risk. Excuse me, it depends on the mutation. So there are certain mutations, as I mentioned, those 4 major genes that we usually test for, that those by themselves are going to cause the pancreatitis by itself. And the reason, so again, I don't want to speak about how every specific mutation interacts with other mutations. The person to probably talk about that is Dr. David Whitcomb.
He is on the panel though.
Yes, but aerial precision medicine, which is often the most, it's the testing that I do most frequently, it will actually go through in a very clear way how the different mutations interact with each other. One example that I think I gave in the case that I showed was the SLC26A9, which also was involved in chloride secretion. And so when you have the presence of that mutation in combination with a CFTR mutation, it's probably augmenting the impact of that CFTR mutation, whereas that SLC mutation on its own wouldn't be causing any type of disease. So we do know that a lot of combinations of mutations are going to increase the risk of recurrent acute pancreatitis, and a lot of it has to do with how they combine with each other.
Of course. And if I may ask you as well, when we see these patients with genetic mutations, we always think of the environment and we think of alcohol and smoking, and that's what we advocate patients. Do you think there's other things as well within our environment, perhaps the microbiome, something else that we may not be advocating or counseling about, but something that we should be considering? What are your thoughts?
I mean, this is certainly a hypothesis, but I think the short answer is yes. There absolutely has to be. And I do think a lot of it is probably dietary and what's ingested, and how it impacts the microbiome, whether it's how it impacts the microbiome or something in the food product itself. We have a few studies that show that highly processed meats or red meats can actually increase issues with pancreatitis in the setting of genetic mutations. And even though very small studies, but antioxidants can potentially be helpful at minimizing the risk at recurrent acute pancreatitis. I mean, I think we need large, robust, randomized clinical trials to really try to answer that. But even with just those studies, I do think that there are things in our environment that we focus in on alcohol and tobacco because we understand the mechanism. We know it's going to cause an issue, but certainly these things exist. And I tell my patients, whole foods as best you can, lots of fruits and vegetables, as much as you can tolerate.
Is there a particular antioxidant of choice that you prefer?
I'll sometimes prescribe, so I'll oftentimes just have a patient start with a ton of giant bowl of wild blueberries every single morning, but in patients where they really have recurrent acute pancreatitis, multiple risk variants, they're not drinking, they're not smoking, they're taking their enzymes, they're watching what they eat, and they're still having episodes, I will prescribe vitamin C, vitamin E, selenium, methionine, like the antioxidant cocktail, so to speak, that was published.
Sure. Well, we certainly look forward to a time when we can have a genetic test as a clinically actionable report.
Oh yes, it'll get there, I think. Not too long.
For sure. Any other questions from the audience for Dr. Barco or Dr. Park? We still have time. Dr. Park, can you shed some light about perhaps the role of endoscopic ultrasound in early chronic pancreatitis? How significant is that? Because we oftentimes send patients for EUS and it comes back as, you know, all these features, lobulation and all. I mean, sometimes we think, oh, some even normal patients can have those findings. What significance does these findings have and how do we take them?
I think you have to take it in combination with any risk factors that they have. So a lot of times if, you know, we see this we do say lobule. I feel like we say lobularity a lot in our endoscopic ultrasound reports. But I think, you know, if there's a lobular pancreas, but the patient has no symptoms of chronic pancreatitis, if they have if, you know, they're not smoking, they're not drinking a lot, I don't think it's anything to really be too concerned about. But I would say in patients who, you know, smoke a pack a day or are drinking heavily, just counseling on them and modifying those risk factors to prevent the chronic pancreatitis from progressing, I think is the most important thing. So you have to take it in with just each individual patient and having a conversation with them. We really do try at our institution to stress to all patients who have signs of early pancreatitis, you know, stop smoking. That's obviously very, very difficult for patients, but that's like our number one, I would say, advice that we give to patients when we are, you know, counseling them is smoking cessation.
For sure. What do you think there's a role for sphincterotomy in idiopathic acute pancreatitis patients?
Yeah, so sphincterotomy, I think you're referring to like SOD, sphincter of Oddi dysfunction as a potential cause of idiopathic acute pancreatitis. Maybe, maybe not, but it's like I don't think we do it first line. I think it's not as beneficial I think it could cause more risk than benefit in these situations. So we don't necessarily go to that as anything first line to perform.
Good. Well, there's a question from the audience which asks that under what circumstances would you consider an tissue biopsy for idiopathic acute pancreatitis?
I would say only if you really see a tumor or a lesion that is not typical. Like I wouldn't go biopsying just pancreatitis that looks inflamed or features of chronic pancreatitis, but certainly if you see a lesion, a mass, a small tumor, or a suspicious lesion, I would certainly do a FNB in those situations.
If I may add, also, if we think there's a high suspicion for autoimmune pancreatitis as well.
Yes. Yeah, correct.
Yeah. Okay. All right. Any other questions from the audience? No. Well, if there are no more questions, then I think this concludes our session today. It's been wonderful having both Dr. Barko and Dr. Park. I thank you both. We learned a lot about both EUS in idiopathic pancreatitis as well as the genetics of acute pancreatitis. Thank you, and thank you all for attending.
Thank you so much.
Thank you.
Take care. Bye.
Bye.